So the aim of squint surgery is to balance the static and the dynamic forces that are bringing about the eye movement. And knowing from past experience where all of us have burnt our fingers, sometimes this balancing may not be all that simple. So just to know, before we actually pick up the blade, I'll just reiterate the important factors which you look for. Looks can actually be deceptive. We've talked about accommodative esotropias, which need not have any surgery. Amblyopia, that needs to be treated before you plan for any surgical modality. Orbital lesions can present with acquired squint, so you have a sudden onset strabismus. Look for other associated adnexal problems. The limitation may be associated with mild proptosis, congestion, or posterior pole anomalies like folds in the choroids, which may show that there is an actual lesion that is there in the orbit that is responsible for the squint. So these things are important. Always ask for variability, particularly when you're not able to identify the kind of squint, when it's not an acquired squint, when it's not falling into a classical nerve palsy. You look and ask for variability. It's very often, and myasthenia is called the great mimicker because it can mimic any kind of strabismic disorder. Finally, before you take up your surgical knife, be sure of your diagnosis. Like this case is not a case of sixth nerve palsy that was diagnosed when it was presented to us. So, it's important to know your diagnosis before you plan for surgery. Again, a lot of adnexal factors make a difference. You need to know that sometimes there may be an appearance of a squint which need not operate, and on the other side, you may have an actual true squint with a pseudo-exotropia. So, you need to know what is your endpoint. Sometimes parents will come back and say the squint is still there, but you know that you've aligned the eyes, but it's because of the adnexal folds or because of the pseudo-esotropia that you feel that there is a strabismus. So it's very important to identify these, inform the parent about that, and manage accordingly. And the other things are the eye movements, the FDT. It's important to free the FDT. Any restrictions before you should be incorporated in your decision making, and before you close up the case, it's important to make sure that the FDT is free. The sensory status and what is your end point of surgery, and associated A and B patterns. We have a lot of weakening procedures, but the recti, the most important are the graded recessions, which can be adjustable with a hangback or a slanted recessions. Farden surgery is there, and for superior oblique, we can use free tenectomies, stenotomies, and marginal myotomies for inferior oblique. For recession, graded weakening is the best, and the muscle is reinserted closer to its origin. It's very graded, effective, and you have a very good idea of how much effect you get. When in recessions in the lateral rectus, remember that the inferior oblique is very closely related. Beware of taking in sutures of the fibers of the inferior oblique, causing an inferior oblique inclusion syndrome. In superior rectus surgery, the superior oblique is just underneath, and for inferior rectus, you have to dissect out the Lockwood's ligament, otherwise you have lid-related changes. There are a certain amount of minimum and maximum that you can do, and these facts are very important for you to know before you take your decision. Excessive recessions can cause palpable fissure changes, and underaction and overaction can be possible if you do larger than what are recommended. For the strengthening procedures, again for the recti, you have the rectus resection, which is the best. Advancements are there, tucking, which is used for superior oblique, and transposition procedures if the muscle action is poor, as in paralytic squints. Resection is a strengthening procedure which shortens the tendon length, making it tighter and making the force transferred more, although there is no total increase in the muscle power. Again, there are maximum levels of resection that you can do, because if you do more than that, you're actually removing the fibers of muscle, which then becomes an actual weakening procedure. So do not go beyond the recommended amounts, and you might have problems. There are a lot of standard nomograms available in the textbooks, and all of us have actually started our squint surgery by using standard nomograms and adjusted as we get more and more experience as per our past surgical result. Particularly in your initial learning curve of squint surgery, it's important to use standard nomograms, because if you get an unexpected result occasionally, which all of us do, you are able to at least stand up and say that I use the standard accepted nomogram and unexpected results are known. But like I said, it's important to plan as per the rules of strabismus surgery that are there. Often we discuss bilateral recessions versus unilateral resect. There's no, it's no hard and fast that one is better than the other. It's beneficial to do bilateral recession procedures because it balances the effect in both the eyes, does not result in incompetence. There are less palpable fissure changes, and if there are changes, they are balanced in both the eyes, so there is no difference that is noticed. However, both eyes are involved, so in adults, you might have to block both the eyes or operate both the eyes, and congestion is there in bilateral eyes. However, unilateral recessed resect, the advantages are that you get an additional 25%. So in large squints, it might be better to do a recessed resect versus a bilateral recession. And then the other problems of unilateral recessed resect are the palpable fissure changes that can be more significant. Considering that the other eye is normal, the patient does frequently come back and say that this eye appears to be a little different now post-operatively, which you just needs a little reassuring. Recessions are stronger than resections. Response of the medial rectus is stronger than the lateral rectus in a ratio of 3:2. So these are graded, again, these are approximations that give us an idea. MR recession of 1 mm gives you about 3.5 to 4.5. LR recessions will give 2.5 to 3.5. Resections of the medial rectus 2 to 2.5, and lateral rectus would give about 1.5 to 2. So these are gross effects that we know of. Again, variations are there because of individual surgeon techniques. We get 25% more effect if we operate one eye. We get more effects in smaller children, particularly infants. The importance is that the surgical plan should not induce incompetence. So do not do large amount of surgery in one eye, because that would cause incompetence and be glaring, particularly in a case which has good vision either eye. He can complain of diplopia in certain gazes if there is a limitation in the post-op period. Do enough, but do not overdo it. Basically, that is the most important rule to go by. Be consistent in your surgical technique, because subsequently you are able to adjust your surgical doses based on your experience. Like in this case, you can see that the left eye is a little smaller, and the patient always comes back and says that this eye is still smaller. So these things may also have to be told to the patient when you're doing one eye. Other factors affecting outcome are the age, response, patient response sometimes which is unpredictable, anatomical variations of muscle position, previous surgery, larger deviations give surgical corrections, give you more responses, the sensory state of the patient, and of course surgical plan as you've planned, whether you want it to be overcorrected, undercorrected, optimally corrected, depending upon your outcomes, and of course unilateral versus bilateral. The factors that vary outcomes are the surgeon factors. You have to be consistent in your placement of suture, the amount of muscle you expose, the dissection you do, the amount of check ligaments you cut. Variability in them varies the outcomes, and that's the cause for unpredictability in your outcomes. There is no real difference between limbal and fornix incisions except cosmetically. Fornix incisions can be a little technically difficult to start off with and maybe a little tougher, and you really need a better assistant than you need in limbal incisions. But limbal incisions are definitely technically easier and get a good exposure, and you don't make a mistake on the muscle that you can operate. We have come across cases where, because of the fornix incision, the wrong muscle itself was hooked. Like A&V patterns we'll be discussing, it's important to operate inferior obliques when you have a V pattern with inferior oblique overaction. Similarly, A patterns, you need to operate the superior oblique, otherwise you will have residual squints or there will be a squint in different cases. We'll be discussing A&V patterns, so we'll skip that. Very large deviations, you may have to plan 3 muscles at one go, or sometimes you can do a large recessed resect in one eye and get a fairly cosmetically good outcome if it is a cosmetic squint, because often the patients are unwilling to get the seeing eye operated. So if the outcomes are cosmetically acceptable, it's fair enough to do one eye, and if required you can do more surgery in the other eye. Often the patients may just be satisfied. In paralytic squints, early rehabilitation may be important. They complain of diplopia. So botulinum toxin in the antagonistic muscle is beneficial, particularly in 6 nerve palsies. Importance for surgical algorithm as far as this is concerned is that when you are deciding surgery, if the eye can move past the midline, you probably can get away with a recessed resect procedure. But if it cannot cross the midline, then you do the active force generation test, if the AFGT is weak, you don't feel a good tug, and looking at the eye movements, you feel that the eye movement is slow, you know that any amount of resection will not actually get the eye to be strong enough. So you may need to transpose muscles and get support from other muscles. Like in this case, there is a severe abduction deficit in this patient. we had to do a half muscle vertical rectus transposition to get alignment in the primary case. However, on the other side, you can see that there is very good abduction in this patient, and we just did a resect procedure to get alignment in the post-op period. Complete third nerve palsy can be very tricky, and you have options of supramaximal recession resection. Again, if there is good amount of medial rectus function available, you can do that. Otherwise, you need to either anchor to the medial orbital wall or remove the lateral rectus from the whole procedure and anchor it to the lateral orbital wall. This was a patient where the medial rectus was very poor post-trauma, and we anchored the globe to the medial orbital wall periosteum. So important to know that although you have a lot of choices, there is a lot of variability and things can be very confusing, but there is no alternative. Good workup, a correct diagnosis and realistic expectations both for the doctor and the patient. Thank you.